You get this feeling at the hospital where there's like a limit to how long you can be in labor. Like, oh, it's been 12 hours, so now you need Pitocin.
Oh, I did know the pressure was on, you know, as we got into like 20 hours, 21 hours.
At the hospital, I had Pitocin, and then that made me itchy, so they give you something else for your itching.
I knew once they gave you that Pitocin, you need the epidural.
Feel better now that you have your epidural? Oh my God, yeah.
And then things come on really strong, so then you get an epidural.
And if you're uncomfortable, we can always give you more.
It was very easy for them to start doing things that we hadn't really wanted them to do, like Pitocin and whatnot, because I already had the IV in my arm.
They don't really give you the option, you know.
And then another epidural, because nothing was happening.
You're having a contraction right now.
I don't feel pain.
Automatically, they were like, oh, you need an epidural. We'll get the anesthesiologist.
So she's getting her epidural, then we'll put in the Foley bulb for induction.
They gave me another drug called Stadol.
17 hours of Pitocin.
They gave me that, and I remember that made me, I was like, what's going on? What's going on? There's something wrong.
Cervidil was the end. Once Cervidil happened, any chance beyond that was gone. It was gone.
I hated that drug.
You know, it seemed to me that once they started an intervention, they all just kind of, it was a domino effect.
The whole thing is like a big snowball effect.
In the hospital, you're not allowed to have very long labors. So if you're not dilating rapidly, which you're likely not to do if you get an epidural early in labor, you will be given Pitocin. They'll put the Pitocin in the IV. It will flow into your veins. Pitocin makes contractions longer and stronger and closer together. So then the pain of labor is much worse. So you go with that for a while because you have the epidural, but eventually the pain of the contractions is overwhelming the epidural. You need to up the epidural, and then labor slows down more because of that, so then you need more Pitocin. Now you're not feeling the pain of the extra Pitocin because you've got the epidural, but your baby is getting compressed blood and oxygen supply because Pitocin contractions last so long and are so strong, the blood and oxygen flow to the baby is compromised. So then the baby's likely to go into distress, and then you're sent off for an emergency cesarean from a baby in distress from contractions induced by the Pitocin, which was necessitated by the epidural.
Step by step, one intervention leads to a series of interventions. And the net result is the mother finally ends up with a cesarean, and everybody says, thank God we were able to do all those interventions to save your baby. The fact of the matter is, if they didn't start the cascade of interventions, none of that would have been necessary.
If you look at obstetrics for the last 50 years, what do you find? In the 1930s, they were giving x-rays on every pregnant woman to measure her pelvis. And then in the 1940s, they discovered that that caused the baby to have cancer. So they had to stop it. And then in the 1950s and 60s, they had another drug called thalidomide, which caused babies to be born without arms and legs. And then they had to stop that. But you see, in every case, it was after the fact. In the 1990s, they were giving Cytotec to induce labor in women who had had a previous cesarean. And they ended up with hundreds and hundreds of ruptured uteruses and many, many, many dead babies before they found out, finally, in 1999, that they shouldn't do that. But you see, there's not a good history in obstetric practice of careful study of the long-term effects of all these interventions.
So concerns have been raised about the high level of cesarean section in the United States. We have one of the highest, not the highest, but one of the highest rates of cesarean section in the industrialized world. The most recent data from 2009 has the United States at 32.9% of all births end up in a cesarean. The difficulty with that is that there's no evidence whatsoever that a third of mothers are high risk, or certainly sufficiently high risk to merit a cesarean. When people have looked at this increasing cesarean rate, it's often argued that it's either because of demographic changes among mothers or mothers' requests for them. So let's look at this piece by piece. It's argued that mothers are getting older, and older mothers are at risk, higher risk, and so they require cesareans more often. Sort of true, except for the part that's false. The false part is this, that the increase in the average age of mothers in the United States ended around 2003, and the cesarean rate has continued to increase at roughly the same pace, slowed down a little bit in the last couple of years. It's said that there's more twin births because mothers are using artificial reproductive technologies, so they're having more twins, and that's resulting in more cesareans because often there's cesareans because of twins. True, except that around 2002 and 2003, that peaked in the United States as well as people got better at assisted reproductive technologies. We don't have the number of multiples that we did before, and that's leveled off, and the cesarean rate has continued to increase. It's argued that those cesareans are going up because babies are getting bigger. That's not true at all. Babies are actually getting smaller. Even if you're looking at singleton births to avoid the issue of twins, the average size of babies has decreased. And it's partly decreased because the injection of early cesareans has resulted in more prematurity. So the final one that's laid on mothers is they're asking for it. That this is simply doctors responding to demands by mothers. And that would be a very powerful argument if it had any basis in fact. The only basis in fact is this. There are clearly a handful of mothers, a very small proportion of mothers who want a cesarean for fear of childbirth, for fear of labor, whatever. But that's a tiny fraction of the number of mothers we're talking about. When we did a national survey of mothers, we found it to be less than 1%. So most of the reasons we cite for the rise in cesareans either are not true at all in the case of birth weight, or have not been true for the last few years as the rate has continued to increase. The question's been raised, what's the concern with the high rate of cesareans? If maybe 33% isn't even high enough, maybe it should be 100% cesareans among some. But the other side of it is this, once you pass a certain point, and there's not a fixed number that everybody agrees on, but oftentimes in the area of about 15%, what you find is the outcomes don't improve anymore. When you look at it across countries, those higher rates of cesarean have no actual benefit for mothers and babies for that matter. But when you start subjecting mothers at low risk to major abdominal surgery, you're introducing interventions they don't need. And then what we found was mothers were much more likely with planned cesareans to be rehospitalized in the first 30 days, in the first 90 days, and up to 1 year. Why would we be surprised by that? You do major surgery on people who don't need surgery and you raise risks of infection that they wouldn't have experienced otherwise. And so the point is not that cesareans are not done well and people don't care about how they do them. They do them with great care. But the reality is doing surgery on people who don't need surgery introduces a set of risks that you don't have to encounter. I don't doubt the sincerity of clinicians who believe strongly in trying to do more cesareans. The issue is how they got to that point, where they came from and how they got to that point. And if you look at the nature of their training is all about risk. And the consequences of that are their behaviors will treat mothers as if they're all about to have a disaster occur. And they don't go home at night saying, ha ha, I fooled all those people. They really believe it. They honestly believe it. And it's that honest disagreement that I find makes it both possible to talk to people and difficult to get people to change. So if you're thinking, where can we make the change would have to come at the training stage. Both in terms of maybe recruiting some different kinds of people whose greatest skills weren't necessarily their score in organic chemistry, but had the kind of compassion and empathy that we want in a birth provider, but also change the way they're trained. There's a wonderful moment in one of the many documentaries now around childbirth where several young obstetricians are asked, have you ever seen a normal birth? And the three of them sort of look at each other and say, well, no. And what does that mean for our system and the way we train the people that we put so much care into?
How often do you get to see a fully natural birth?
Rarely.
Almost never.
This is why, if you really want a humanized birth, the best thing to do is to get the hell out of the hospital.
And as a physician, when you go to the hospital, the standard of treatment and therapy and evaluation is not yours. Now, see, you have to understand that's awesome. And you women especially need to wake up to that. You keep running to these institutions and they keep seeing you as a white girl. Now, how are you going to actually ever get better when the treatment is for a white girl? Now, our whole bone structure, physiology, anatomy, and development is different than theirs. Normal hemoglobin for us is between 10 to 12. So that means if your hemoglobin is 10.5 to 11, you are normal. And so when they shove iron up in your face to make your tissues hard as a rock, you're the fool. Because you didn't know who you were. Now, for a white girl, that's the proper treatment. So now, why don't you know who you are? That you have to ask yourself that question. And why you continuously rely on institutions that refuse to see you as who you are and treat you as who you are, you have to ask that question. But truly, if I was Henry Ford and I had $70 million to put in an institution, and I was interested in my family and my children being treated, oh yes, I would always be the standard. Be no question about it. So if they had to pick me up off the street or roll my kids in, they were always going to be able to be the standard. Now, the key here is that we're looking at some false marketing. Because they put these signs up all around saying that they can help you, but they can't because they do not use your standard when you come in to get treated. Now, the Orientals know that, and the Eastern Indians know that. That's how come you don't see them up in there. They understand that. So when they need help, they have their own medical system. They don't even go up in there. I mean, they are that intelligent, they know that. So that means then that if you haven't then come together as a group of people and put your money together to build an institution, then now what are you going to do?